I got the thing to talk about is a team expectation when restoring the full arch. As a lab technician, obviously, I see sometimes the other side of it. And sometimes what we have to go through is the challenges to bring the digital together. And not only that, just the workflow to get everybody trained on how do we do it from step A to Z. And that's sometimes, I know that the guy sitting in the front row here who's been speaking here, obviously, they're some of the top guys out there, but we also want to bring everybody else to the same level. We want to take you to the next level to show you what we do. And obviously, I just want to show and thank you. This is from the Vegas show that they did, and like I say, I changed it from dental expectations when relaxing with the dental XP technologists and clinicians, because it's always a pleasure to hang out with these guys and to learn from these masters, and there's Tyler, yeah. So it is the responsibility of the team to be the architect of the comprehensive plan. And we've heard a lot these past couple of days about the team and how important it is for all of us to discuss these cases from the get-go. Even as I get involved in the CBCT planning myself as a technician now, and you've probably noticed that there's a lot of laboratories out there that do the guided surgeries and do that for you as they're milling the guys. Not only are they involved in the planning. So it needs to have some very good communication. And we've seen a lot of really neat things here during these 2 days on digital smile design, and not only that, on 3D digital smile design. I'm very excited to jump into that even further. It is so important, like I say, these patients aren't coming in for implants, they're coming in for the teeth. And like we say, when we start the treatment planning, we start from the beginning, from the general dentist or from the surgeon. Just think about the full team as we're going to deliver these teeth, that lab technicians need to be part of that already from the start. So what we start with, obviously, is our communication. It's photography and video. And we've all seen a lot of that information today, but I always want to talk a little bit more about it because we utilize today more videos to communicate with the lab. And we can see things in these videos that we aren't used to see as a technician. We see different angles. We see the lip movement. And all this, like I said, from Christian Coachman and the DSD, being able to do a simple setup like this, we can very easily record the information that we need for communication. So it's the facial diagnostics that we have to focus on first. We're going to go through the principles of the prosthodontics as we go through the case. And again, being able to utilize something like digital smile design to just give the patient the vision of where we're going, and at the same time giving us the tools digitally to be able to transfer that three-dimensionally to the model. We can do that in an analog way. We can do it in a digital way. There's been a lot of digital things going on today here, and I know it's sometimes overwhelming, and you're thinking, where do I start with this? So, starting with the photography, we go through the symmetry of the patients, and we give them a visual. If we do that with a mock-up or we do that with just a visual thing for the patient, is how we're going to set up the case. And again, we've seen a lot of 3D stuff today. This is a little earlier works of 3D, obviously. But it's very important that you have your lab technicians on the same page when we start. Because like I say, it starts with the teeth in space. We have to work out the phonetics. We have to work out the smile line. We have to look at the photography. And then from there, backtrack to the implant placement. And we saw some beautiful work just the lecture before here about how now we can design these guides very differently. And we start thinking outside the box. So on the surgery day, obviously, that's where we make the difference in the patient's life. If we do an immediate load surgery, or we're going to do delayed, it's about designing the smile for them and the dream that they've been wanting this whole time. And if that's going through navigation guided surgery, which I think where we probably are going more and more, instead of the static surgical guide, I think we're going more and more towards navigation guided. And we'll probably see in the next 5 years, 10 years, so you're going to see a revolution coming through with that. And it's some neat stuff that we can do with that, but it's still based on the aesthetics, based on the function of the patient. But you obviously have a lot more freedom, and this is my friend Michael Block. I worked a lot with him on that. That's going to build us the foundation where we're going next. And again, what we talked about, and we've discussed this, is about going to the abutment levels. It is so important from a perio standpoint, and going through the ease of transferring the information to the laboratory. It's a lot easier for us to work on an abutment level, specifically on the full arch cases. Then it becomes materials. What are the materials we're looking at today that we're going to use? We've seen a lot about zirconium. We'll talk about zirconium, but there's a lot of other composites out there today that's very interesting on the market. And there's specifically a big group in England that talks about this, who's bringing in some nanocomposites and some interesting material. So the complication as we start, this is a lot of times what we see as we get into the cases, is that we have a train wreck. And we're going to figure our way out of this. So we have to see a protocol. We have to, again, what we saw earlier, all the different involvements of all the team members. And we have to get involved early on this. So bringing a lab tech in, we can start talking about the materials. And what are the materials we deal with, and what are the downfalls of the material that we use? Because we have seen, in the past 40 years, we've done acrylic hybrids. Has this really been the best restoration for our patients? Because these patients, they really weren't the best, didn't have the best hygiene as they started out. And we're going to give them a material that might be cheaper. It might be soft and easy to work with, but we have to consider what happens if we don't give them the space, again, like I say, the planning of it from the beginning. Because in the laboratory, a lot of times when we get these acrylic hybrids, the first thing I talk about is vertical. What is the vertical that we need? And that's how we're going to plan out the case. Because that's going to tell me in the beginning, when I'm looking at the CBCT plan, I'm going to vision where my prosthetic's going to be. I'm going to see where the bone are. We're going to place our virtual implants in there. And if we then go to the guided surgery, we got to make sure we have the space for the material that we have promised our patients. And a lot of times I see it being undersold, unfortunately. I see they going for the cheaper version. It comes to the lab. Suddenly I'm stuck at the day of, and I'm saying, I can't do that. Not that I can do it, but like I say, do you really want me to do it? Because these measurements are so important, because this is what happens. Acrylic wears, and not only when the acrylic wears, what happens, the vertical wears. Now suddenly the posterior teeth are there's higher occlusal forces on the posterior teeth, and the anterior teeth are in contact. We start seeing a further wear, and suddenly start breaking down the prosthesis. And they'll put a lot of trust in you on these restorations. So that's why when we do these, we have to tell them in an average of 5 years, we're going to have to take this prosthesis out, and we got to start over again with the new tooth setup. And obviously, the problem we have with these restorations a lot of times is that this is the only sample you have of that restoration. What are you going to give them when you say, I need that out of your mouth and I need to send that to the lab? Or we need to set new teeth on that. The neat thing with the digital dentistry today is that we can actually scan these in when we make them. And if we know 2 weeks in advance that you're going to restore this again or rethread it, what we call, all we do, we actually print you or mill you a prosthesis that you can now exchange. So again, digital dentistry comes in on even the analog world as we work with it. And the materials, obviously, we know from the studies, Michael Maskovich has done a lot of studies up in Canada. There's several articles on this through the years on zirconium. And this is where I see us going more and more today, to zirconium restorations. If that is now as a monolithic or as a micro-layered prosthesis, that all depends on how we set it up in the lab, how they can work with it. The digital technology doesn't always make it faster, easier, and cheaper. We have to think about that because we know how it is with your cell phone, with your laptop. In 6 months, there's going to be a new one, you know. iPhone 7 is coming out now. I just got an iPhone 6 Plus just the other day, and I'm like, maybe I shouldn't have done that. All right, maybe I should have waited. So it is changing constantly. And again, with the digital dentistry, we're moving fast. And we saw Marcus Abud talking about it, that's how we're looking ahead of this. We looked at the surgical guides that we've seen from Scott Gans to our recent speaker here. It's that it changes, and it changes fast. So we have to be prepared for that. But the materials, again, we're coming back to, we need to have a material in our restorations for these patients that's going to last. We have done a lot of metal ceramics, and we know metal ceramics is on the way out. Still, though, we can probably create better aesthetics sometimes with metal ceramic in certain areas where we're lacking verticals and we need strength. Because these materials, even though it's zirconium, if you start thinning it out, you're starting to go on thin ice with those restorations. We do these restorations cement retained. And again, that's what we talked about, the emergence profile. Do we need emergence profile in a case like this or not? How are we going to transfer? What are we going to do with the cement line? Sometimes these cases, we've gone in, if we haven't been involved in the treatment planning on the surgery, a lot of times we deal with, like we saw Dr. Booser showing implants sticking out all over the place facially, and that's what I see a lot of times. I see the implants placed too far facial on the ridge. And now we're going to redirect that. We can't do a screw retain restoration because, like Scott Gans said, it's a three-dimensional placement. This is not just a buccal lingual placement, it's a vertical placement too. Once you go and the biotype of the tissue might be thinner, now if you're going to put an angulated abutment on, you need extra 2.5, 3.5 millimeters of vertical or tissue thickness just to re-angulate it 17 to 30 degrees. So we have to think about that. It all comes into the planning again and having everybody on. Even with full arches, it's not always that we need to do fixed. I think something that's underused today is removable dentistry. If it's crown and bridge removable or it's implant supported removable, we have to think about these patients and how they're going to handle the prosthesis over time. Because we know the history now of implants, we have good integration. And obviously we know that the implants that are usually misplaced, they integrate the best. And we have a hard time taking those out. But we have to think about these patients long term. So everybody talks about fixed all the time, but I think we have to look at the removable prosthesis as a very good solution. If that's a bar overdenture case, or in this case, maybe too many implants, too many locators, okay, we need to plan this out. And then, obviously, yes, if we can go to fixed, I do prefer the zirconium restoration today. But what's challenging with this type of restoration is that it's a totally different protocol. We have to think differently as we work with our team members. The surgery might not be different, but when you as a restorative dentist going to work with the lab, you have to think differently. Because it's such a hard material, and we can't really grind on this prosthesis without possibly creating microfractures and getting issues. And we've seen, like I say, Michael Maskovich did some 7 years of testing. I'm not sure how many units he had in his study, but he has 0 failures. Well, I've seen failures. And I think what's going to happen is that the way we work with these prostheses is that if we cut out steps in the protocol, you're going to start seeing failures, and it's going to give it a bad name as we go through these. But we can create some beautiful restorations for these patients, but again, there's a restorative workflow to follow. And it's not the standard that we take our implant impression, we go to a metal try-in, we then bake the porcelain, we go through it. No, we're going to go through a step of prototypes. And that's the training wheel that we have to go through. So we start with our evaluation of the bite room, and I know Christian Coachman talks about this, and this is something I believe very highly in, is that The types of photos I never ever get as a technician is of the bite rim. Because I trust too much looking at when you take, we're giving you a bite rim. First, it can be a technician who doesn't really know how to make a bite rim. Where's the occlusal plane? We don't have that. We don't have anything mounted at this point. We go from our numbers of 22 millimeters, 18 millimeters. And now you need to work on that bite rim. What I would do once you've worked on the bite rim, I would take the same photographs as you take if this was teeth in there. Because now we can go in and we can measure. We can take our measurements. Let's see, where's the clip? Here it is. We can look at the buccal, the incisal ledge position from a profile view. On a 12 o'clock view, which is probably the most important photo that I see, is that I can see the curvature. Is that following the lower lip that I want? Is it centered in the face? So I go in and I utilize DSD, and it's a very simple process. In this case, it's not so much for the mock-up, but it's for following up the case as I'm checking it myself as a technician. I can mark the midline, I can mark my canine position, I can take my measurement exactly where do I need to correct it. Because when you work with wax in an edentulous patient, it isn't that easy, and we all know that. And fortunately, in schools today, we don't learn enough about removable dentistry, and that's something we need to start doing a lot more of. Once that is, we're going to create the setup for you, and we're going to make sure that this is a screw-retained setup. It's going to be fixed into the implants because I don't want it to move anymore. I want it to be fixed. I want to be able that you can take the proper photographs, have the patient wear it, and really see that is this working in the smile? Is the profile right? Is the length right? From that, we go into what we call the lab communication prototype. And this is a PMMA milled prosthesis from the wax up. And in this case, I have wax here for the pink, so we can adjust that easily. Because I'm not just looking at the occlusion at this point, I'm looking at the gingival adaptation. I'm looking at the hygiene that patient's going to be able to perform on the restorations. So it's very important, again, looking at the video, making sure we have the proper function. And not only that, if it is, this is a PMMA prototype. You can grind on this. This is like what you trained in dental school, work on your provisionals. I see far too many times we do a denture setup. And as soon as you start grinding on that tooth, it starts to move into wax. And now everybody starts pushing the teeth back in and everything, the wax starts heating up, and we're in a mess suddenly. So a lot of times I see cases coming back and they've never touched them. And I'm like, I can't believe that. I was like, why? I thought there must be something that's not right here, because otherwise we guessed very well, you know. But in this case, it's very easy to adjust that. And that's a true benefit in doing these PMMAs. The next thing, I don't have any sound here, but we check the phonetics of the patient. We're going to listen to the S and F sounds. We go back to our prosthodontics principles of teeth in space, phonetics and everything. And again, we take photographs at that step. Again, we double check each other. So I'm going to double check. Do I need to move again? Do I need to move these teeth again? Yes, we understand. We know about the midline. We can have a midline discrepancy. But if there's a can't, I need to take care of that. So again, I go backwards again, just as a technician, because again, these patients are coming in for their final restoration. They don't want to do any more dentistry after this. I want to make sure this is right. Not only from the biological standpoint, which all the gentlemen who's sitting in front of me here have taken care of, hopefully, you know, so I don't end up later on that we have some issues. And I hope you guys have learned from these guys today and yesterday, because they are tremendous. Then we're going to go back to what we call a functional prototype. This is a prototype. The patient's going to wear this. They're going to wear this for a couple of weeks. This is our training wheels. This is our test ground. Now they're really going to work on it. We're going to see, can they keep the hygiene that they promised you, which we know a lot of times is a hard thing. Is the teeth, are they happy with it? Are their wives happy with it? Are their husbands happy with it? You know? Is everything right? We can look at shades, and again, from this standpoint, we can change that. So even though we think with everything digital and everything that we're doing with nights, we have to double check ourselves. We have to go back and see what we've done and what can we improve for the next case and what can we improve for this patient. So in that transformation with the PMMA, we'll be able to really see how is it working out in the smile line. So this is the upper and lower PMMA prototypes. This patient actually had a very gummy smile, and it's sometimes hard with these patients. And this is where we go back again from when we do the surgery. Are we getting the junction of the prosthesis so it's not going to show? That all has to be planned out in advance. Another patient, the same thing, prototypes. And I keep these patients in the prototype for a while because I want to make sure is that once we do it in zirconium, I'm not going to back from that. And there's going to be a signature in that prescription because that's just too costly. These treatment plans aren't cheap for these patients. We've got to make sure we have it right. So then we go back to the digital workflow. And in the lab, we've been in the digital world now for quite a long time. And we're probably about, I would say, still about 5-10 years ahead of you. We used to be about 15 years ahead of the clinicians. Now intraoral scanning is happening. CBCT is happening. All this is coming in now. And what we see in the lab now is we have to start speeding up a little bit. We got to learn about what you're doing intraorally because the intraoral scan is very different from when we do a model scan. And we still know that the model scan is more accurate at this point still than the intraoral scan. So in digital dentistry, I call something fear. Because everybody out there sitting and saying, I want to do digital dentistry, but I'm not sure. How am I going to do it? So either you forget everything forget everything and run away from it. Or you face everything and you rock with it. Because that's the way to do it. And you've seen all the speakers today. I mean, I don't think there was one speaker that didn't speak about digital. Well, maybe Howie. But he does a beautiful work on the bone. But you use CBCT, So we have to embrace this. And that's what I call the fear factor. So we go in and do that. And in the laboratory, everybody's seen this. And more the labs are getting involved with the zirconium and how we stain these prostheses, how we work that out. The next thing that we have as a lab, and I was just speaking with the IDS people out here, the next step is that there's so many implant systems out there. Do we have the components to do this? Because that's the biggest thing in the lab. Everything's moving so fast. We want to get in on this. Does every implant system have a component that we can use in the lab? Is it compatible with our CAD/CAM systems in the laboratory? We all know about the FDA ruling about labs that's been stricted now that you can't mill your own components. We have to stay with the company components, unless you have a milling machine that's been approved. And sometimes, like you see here, this is a stock part that had to be ground down. So we still have to sit in an analog world and do this, which we wouldn't have had to do really if we had chosen a system that was planned, that had all the components. And that's the first thing when we talk to the implant companies, and I talk to these guys, is that where is your CAD/CAM support for the laboratories? So when you look at an implant system, make sure that they have everything for your whole team. Sorry?
What did they say when you asked them?
These guys do have parts, but they're not in the 3Shape systems, and they're not in the ExoCAD system. So the problem is they have to work very closely with these companies. They have to work very closely because we have to have the file on that. We don't want to sit there and spray these and scan them in because it's not going to be as accurate. So again, we have to go back and understand that. Even in our furnaces today, do we have cameras, infrared cameras that tells us the temperature? Because when we work with the material like the zirconium, the way it cools down and heats up is far different than it is when we used to do metal ceramics. So the monolithic zirconium, if we do microlayered of pink, or we do microlayered of enamel, there's two ways to do this. We can work with the full monolithic restoration, still not being able to do the pink in monolithic, but we can do at least the layering, the enamel part of it in monolithic materials. And there is a real technique for that, to get that correct. So even at the delivery, like I say, we're going to use what I always use, the Teflon. And here's a case, for instance, this is a full monolithic restoration on top, and there's an acrylic hybrid on the lower. And that's another discussion that we come into. Can we use monolithic in both arches? Are we afraid of the hard material, the impact force of these materials? There's still studies to be done on that. I haven't seen anything bad about it, and I haven't read anything of any studies, and there's still more to come with that. So here's the patient that we started. This is what you came in with. That's the pre-op, and we can see she had a lot of removables. And we'll be able to give back the youthful look and the function for this patient. As she had her dentition, this was the immediately loaded prosthesis, and we know that sometimes when we still do that, we don't get there 100% in that prosthesis. We got to go back, do our prototypes to be able to deliver the final restoration. Same with this gentleman. Full upper lower zirconium restoration. And the hardest thing for us as technicians is always to do in the pink. That's still a training and a lesson for us to work with the pink. And here's the patient where she started. Somebody did an all-in-4 immediate load on this patient. We can see what the issues were. We got her back in her prototypes, and we're able to deliver what she had as she much younger. So people may not remember exactly what you did or what you said, but they will always remember the way you make them feel. So if we can bring this youthful look back to them, that's the way to do it. And I know I'm doing this faster because I know we ran late before, but thank you very much.